Let us put ourselves in the holy presence of our Lord. Our dearest Heavenly Father, thank you for making all things possible. We are grateful for all the blessings you are pouring upon each one of us, despite the challenges we are all currently facing. Thank you for blessing us today with the wonderful opportunity to meet virtually and learn together in the awesomely exciting webinar. May your blessings of wisdom and guidance be upon us, all through the sharing and impartation of knowledge and skills by our resource speakers, facilitators, and moderators. May all of us learn together, upgrade our competencies, and capacitate us to be the help in the development of our learners' lives and communities in the spirit of your love and generosity. May we now humbly commit every part of this webinar to you as we all bring you the glory, honor, and praises for your kingdom and holy name's sake. All this we pray in the precious name of our Lord and Savior Jesus Christ. Amen.
Through the dreadful darkness, we shall lead the light and lead a path to wisdom. Our will to be our light. To those in pain and suffering, we shall hear a call. With arms to care and comfort, compassion above all, to face a brighter future, bound in unity. The Philippine College of Physicians, we shall be hand in hand, building a stronger nation. This
The Philippine College of Physicians, through the Committee on Media Communication and Health Forum, presents its bi-monthly lay forum to promote the advocacies and mission of the college and its component and affiliate societies. An avenue of accurate and up-to-date conversations with the media and the general public, with timely and diverse topics covering vital public health and medical information, straight from the experts. In a platform that is convenient, accessible, and highly engaging. Welcome to the PCP Health Forum.
Hello and good morning, everyone. Good morning and welcome once again to the Philippine College of Physicians Health Forum. I am Doc Kat Tuhino, the moderator for today's Health Forum. So I would like to welcome all the viewers that are watching this Health Forum through our Zoom, our fellow PCP colleagues, our fellow medical practitioners and healthcare workers, our very supportive media partners, and our avid viewers that are watching this through either Zoom platform or our social media platform that are live streamed in YouTube and Facebook. Welcome and thank you again for all who are joining us today. So for this week's Health Forum, the PCP Committee on Media Communications has collaborated again with the Hepatology Society of the Philippines on a very timely and relevant health topic that has also been one of our major global health problems. The title for our health forum for today is The Current Treatment for Hepatitis B, Tackling Your Concerns and Mine. So to give us the opening message for today's health forum, I am very honored to introduce one of the incumbent members of the Board of Regents of the Philippine College of Physicians, Dr. Juan Maria Ibaraco.
Good morning, everyone. On behalf of the Board of Regents of the Philippine College of Physicians, welcome to this week's online health forum. Hepatitis B remains to be a formidable challenge that requires our undivided attention. It is a chronic viral infection of the liver that can have severe consequences, including liver failure, cirrhosis, and even liver cancer. In the Philippines alone, the burden of hepatitis B is substantial, with millions of Filipinos living with the virus, many unaware of their infection and the potential risks they face. Today, we are privileged to have as our keynote speaker a distinguished authority in the field of gastroenterology and hepatology, Dr. Jose Soliano. With his wealth of experience and expertise, Dr. Soliano has been at the forefront of advancements in the treatment of hepatitis B, playing a vital role in shaping the landscape of care for affected individuals. We eagerly anticipate his insights and guidance on the current treatments available, as well as the latest research and breakthroughs in the field. Today, we reach out to the lay public and the media, recognizing the essential role you play in disseminating accurate health information to the wider population. By fostering collaboration between healthcare professionals, the media, and the public, we hope to bridge the gap between knowledge and action, empowering individuals to make informed decisions about their health. This health forum serves as a testament to the Philippine College of Physicians' unwavering commitment to excellence in patient care, education, and advocacy. Our organization, comprising passionate and dedicated physicians, strives to promote evidence-based medicine, raise awareness about the various health concerns, and actively contribute to the well-being of the Filipino people. We thank and congratulate the Committee on Media Communications for their tireless efforts in organizing this event. Their vision and dedication have made this forum a reality, enabling us to come together virtually to address the vital issues surrounding hepatitis B. Together, let us pave the way for a future where hepatitis B is no longer a daunting challenge, but a condition that can be effectively managed and prevented. Thank you, and may this health forum be a resounding success. Good morning, everyone.
Thank you, Dr. JM Ko, for graciously opening our health forum for today. So before we start our session proper, may I remind everyone if that you have any questions or comments for this health forum, you may type or write your questions on the Q&A chat box in our Zoom platform, as well as the comment section in our social media platforms, YouTube and Facebook Live. And then later on, we can answer these questions in the Q&A portion of this health forum. So for today's health forum, we have a very renowned and expert resource speaker on this topic in hepatitis B. So the speaker for today is Professor Jose Soliano. We all know him as our past president of the Philippine College of Physicians. He's also the past president of the Philippine Society of Gastroenterology, Hepatology Society of the Philippines, and the Philippine Society of Digestive Endoscopy. He was also the past president of the Asia Pacific Association for the Study of the Liver, and he is the professor of medicine at the University of Santo Tomas, Manila. He was also the founding president of the Inflammatory Bowel Disease Club of the Philippines and co-organizer of the Crohn's and Colitis Philippines, a national IBD patient support group. He is also the chief section of hepatology at the University of Santo Tomas Hospital, as well as he has received the Lifetime Achievement Award in the Philippine Society of Gastroenterology. So we will welcome Professor Soliano to be our speaker for today. And then for our moderator for the Q&A portion, we also have Dr. Karen Estel de Lunas. She will be our moderator that will help with the discussion on hepatitis B. She is a doctor of medicine and had her residency in internal medicine and fellowship in gastroenterology at the University of Santo Tomas, as well as a fellowship in hepatology in the National University Hospital in Singapore. She is currently the Public Relations Officer of the Hepatology Society of the Philippines, as well as an active consultant in the St. Louis Hospital, Tacurong. May I now give the floor to our speaker and moderator for this health forum. So welcome again, Professor Soliano and Dr. De Lunas. So Professor Soliano, you may take the floor po.
Okay, thank you very much. Thank you for that very kind introduction. I hope you can see my slide now. Congratulations to the PCP. For having this forum. I believe that in the past we had these meetings for the press in a restaurant in Morato, and that was face-to-face. Now we are doing this, virtual, but hopefully in the future it's going to be live again. And of course, thank you to the Hepatology Society of the Philippines, to the president now. I feel very honored to lecture in front of the president of the HSP, Dr. Wendell Espinosa. And of course, in this forum, one of my students is my moderator. Now she will be asking questions to me, and I'm not asking questions to her. So this reversing the role, which I think is going to be helpful for everybody. I realized that July 28th is the World Hepatitis Day, and we are 10 days before that. And I think this is a very good way to, up the ante, and hopefully that by the 28th, everyone in the country is talking about hepatitis B and hepatitis C as well. So congratulations to the HSP for the efforts on the campaign for hepatitis. I don't know why I cannot. Okay, so my topic today is a few questions that I will ask and probably answer, and hopefully that some of these concerns that really strike me also will be able to answer some of the concerns that you have, especially the specialists who are listening to us, the family physicians, and hopefully the general public. When I was preparing for a talk a few months ago, I came across this article by Anna, which basically asks the questions on hepatitis B treatment, what we know now and what remains to be researched. And I thought that this is a really good challenge to answer, hopefully in this particular meeting in 30 minutes. And I hope that some of the questions that I'm going to ask are the relevant ones. This is the landscape of the treatments for hepatitis B today. At the moment, most of the injections or the injectables have been gone from the market, like interferons. And now we are in the oral therapy, both for hepatitis C and, of course, hepatitis B. We have achieved a successful research and translation to general care of hepatitis C, because today we can cure hepatitis C. But at the moment, hepatitis B is not curable yet. If you look at all the schema that is seen in this cartoon, some of these targets have been explored before. Look at interferons, for example, and of course, look at polymerase inhibitors that have been quite successful. The most successful so far, of course, are the polymerase inhibitors, the nucleoside or the nucleotide analogs, as we call them. But there are many other candidates in the process, like we have tried cyclophilin inhibitors in the past, nucleocapsid technology, and we have not really succeeded. Some have tried preventing virus entry into the cell, but all of these are quite unsuccessful. I'm now involved in a protocol for therapeutic vaccines on patients with hepatitis B who are stable in their nuke therapy. And I hope that this will offer some hope for the patients in the future. So therefore, there are a lot of unmet needs in chronic hepatitis B management, and I'll tackle about 6 or 7 questions today. So the first question, of course, is because we are giving nukes or nucleotide analogs or nucleoside analogs to our patients for a long time, are they really safe? What is the issue about long-term treatment? Is this like antihypertensive therapy where many of the complications, side effects are manageable? Well, one reality is that all our patients who are taking nucleoside analogs are getting old. They've been on the medicine for 5 years. Some of my patients have been on the medicine for 10 years, for example. And clearly, there are issues that are coming with age. In this particular cohort that Grace Wong reviewed in Hong Kong, like 35% of their patients are beyond 60 years old. Some of them are on steroids and other medications that can have issues on the bones. Some have kidney issues because of their hypertension or the diabetes, and some have low phosphate, and some are on hemodialysis and on RRT management. So there are therefore issues that we need to be able to identify in patients and see whether these drugs are quite safe. In a cohort of Asian patients that are reviewed by a Korean colleague like Professor An, he has shown that in patients who are given a better drug, for example, tenofovir alafenamide, which is a pro-drug coming from tenofovir, they have shown that in patients who have been given a bone-friendly and a kidney-friendly version of the nucleotide analog, there's an advantage in the patients and the proportion of patients whereby issues on kidneys and of course on bone are shown in this particular slide. So therefore, in certain individuals, we may have to shift from what is an effective therapy to a more safe and yet effective therapy as well. And I think we are lucky that we have the alafenamide molecule today available to our patients. So in this slide, we recommend, for example, that in patients who are in these bullet points here, over 60 with bone problems like chronic steroid use, history of fragility, fractures, osteoporosis, and of course in patients with kidney issues, it is important that if these patients are drinking or taking tenofovir disoproxil, then we need to shift them to tenofovir alafenamide or entecavir. Most of these drugs today are very inexpensive, and hopefully that our patients can be spoken to and safely shift to these safer medications. And on consensus panel that we participated several years ago and published a consensus statement for the Asia Pacific, we recommend that in patients who have comorbidities of renal disorder, we need to consider using safer nucleoside analogs in those patients with hypertension, diabetes, cardiovascular disease, and of course, other autoimmune diseases. And down in the slide are also patients who have issues on bone, for example, history of fractures, hyperparathyroidism, nutritional issues, and of course, endocrine disorders, which increase the risk for bone disease or osteoporosis, and of course, later on, pathologic fractures. So these individuals need to be spoken to maybe start from the very beginning, at least entecavir or tenofovir alafenamide. These are additional population of patients which we might need to discuss about giving safer nucleotide analogs, especially in those patients who are also taking co-medications that are toxic to both the renal and the bones. So therefore, in our treatment today for chronic hepatitis B, it is important to identify which patients will probably need treatment. That's important because some of our colleagues are treating patients who might not need even treatment. And of course, when you start treatment, then you need to start with safer molecules compared to some of those with some unsafe side effects. So in this particular issue, I think we need to therefore continue this advocacy because we are in the midst of a very, very high density of hepatitis B infected individuals in our population, and yet the uptake for SBV antiviral therapy is quite low. Some patients do not even know that they're sick with hepatitis B, and therefore we cannot identify them and treat them. And so what the SSP is doing today and the PCP is, of course, increase the awareness for patients to seek treatment and to seek consultation so that we can identify the patients who need treatment. We know that tenofovir alafenamide is a good drug, for example, and entecavir is another one that is safe for the bones and for the kidneys, and therefore should be the first drugs of choice for these patients. In patients who have developed entecavir resistance because they were exposed to lamivudine in the beginning and now develop entecavir resistance, I think tenofovir alafenamide is also a good alternative, and we can discuss that in the open forum later on. And we would like you to read this particular article because this is going to give you a very good guidepost, cookbook type of treatment algorithms in the management of your patients with chronic hepatitis B. Now, we all treat patients with nucleoside analogs, and we all treat patients that have elevated DNA. And the final trigger for treating hepatitis B patients will be if they have abnormal ALTs. So is nucleoside analog therapy able to normalize ALT? Yes, of course, they normalize ALT, but not all patients will have normalized ALTs, and we have issues about metabolic syndrome, which I think I will deal later on in the last part of my talk. And of course, clearly, if patients are supposed to respond to therapy, they should normalize ALTs because ALTs are the surrogate markers for liver inflammation. It is important to realize that if you are successful in your treatment for the virus, then your liver inflammation should come down. And therefore, ALT normalization is part of the objective of the treatment while the patient is on treatment. Now, we know that in patients who are able to achieve ALT during the first year, most of the research have shown to us that these are the patients who will not develop decompensations during treatment. That's one, because meaning that their inflammation, which was unchecked and untreated before the treatment, has been mitigated, and therefore their liver function is going back to normal. And most of our data shows that these patients are the ones that will really go on with treatment without any event. All data today pointing to the fact that if patients who are on treatment, especially with tenofovir alafenamide in the trials that we have done, all patients who have achieved ALT normalization during treatment seem to achieve as well the outcomes that we like. All right. However, in case that the patients are unable to have a normalization of their ALTs while on treatment, we may have to rethink and investigate for further causes of these ALT elevations. So therefore, when you are going to treat a patient with chronic hepatitis B, make sure that A, you suppress the virus replication, and that is documented by a negative HBV DNA PCR. I usually do that about 6 months after I start therapy, and that is the first objective that you need to do. Check that your drug is effective against the replication of the virus. And the second laboratory test that you need to do is, of course, check for ALTs. Because if the ALT has also come down together with the negativity of your DNA, then that means that your drug is good and your inflammation is in check. However, there are patients who will be negative for DNA, and yet they will still have elevated ALTs even during treatment. That is a concern because A, we know that in patients who are on treatment and do not achieve ALT normalization, their response to treatment might be suboptimal. Second is you need to investigate further because there might be other comorbidities that the patient may have that can cause as well the persistence of the ALT elevations. Now, this is a summary of the work that my colleagues in Hong Kong have done, for example, in patients who may have ALT normalization, as well as, of course, those patients who may not have ALT normalizations. As we said, the patients who have chronic hepatitis B and might really get a very, very active outcome, or a very desirable outcome with nucleoside analog treatment. These are the baseline characteristics of patients who will, for example, achieve ALT normalization in this study by Grace Wong. If they have low baseline DNA, if they are E negative hepatitis B, or the anti-HBe positive chronic hepatitis B, and of course, if their fibrosis is still early, and genetics or gender seems to play. If you're male, you also are sure to achieve ALT normalization, and of course the drug. If you use the alafenamide, it seems that it is better compared to the other nucleoside analogs. Patients who have no other risk factors for inflammation of the liver, especially metabolic syndrome, will also be likely to achieve ALT normalization. And therefore, this another common disorder that is plaguing the world today, metabolic syndrome or obesity, is another important factor that you need to check and investigate and hopefully control while your patients are on treatment for their chronic hepatitis B. As you can see here, metabolic syndrome is important because it is associated with liver fibrosis, progression, cirrhosis, and then cardiovascular deaths in specific patients with chronic hepatitis B. And so therefore, in chronic hepatitis B treatment of obese individuals or patients with the components of the metabolic syndrome, this is part of the discussion. We recommend that you can take your statins because these drugs are good for the metabolic component, but you should not use this in order to treat for hepatitis B or even treat for SGPT elevations. We also know that statins have some protective effect against HCC and hepatic decompensation, and therefore this can help in the total and comprehensive treatment of your patients. All right. Now, the third question that I have is, if you're going to give nuke therapy for a long time, what are we aiming at? I think it is important to, again, remind all the audience that, when you treat hepatitis B patients, the common error is you only get an HbS-AG and everything else is negative, including ALT normalizations, and patients are treated. This we see 20 years ago, this we see 10 years ago, and this we still see today. Or we saw them 20 years ago, we saw them 10 years ago, and still we see them today. So what is the aim of therapy when you have only normal ALT and just an HbS-AG positivity? There's really nothing that you can measure in order to assess treatment or success. And so please do not treat your patients who are only HbS-AG positive in your serologic examinations and their ALTs are normal. We also tell you that even if their DNAs are 100 million or over, as long as their ALTs are normal, you also do not treat these patients. So therefore, the treatment for patients with hepatitis B, and we've repeated this all the time, is a very, very well-defined cohort of patients with the proper laboratory abnormalities before we start treatment. And these are indicated, I think, repeatedly, and that's been in our consciousness for the long time. But I want to remind all the audience today that we just don't treat anybody who has HbS-AG seropositivity in their blood exams. So if we're going to treat patients, we know that the objective is to really, hopefully, remove HbS-AG. And so is the important question now is, do you treat these patients for a really long time, a lifetime, so that you only stop treatment when you get HbS-AG seronegativity, or what we say a seroclearance? I think we have some studies to show that indeed it is quite difficult. In this review by another colleague from Hong Kong, he reviewed 34 studies looking at 42,600 patients with a follow-up of about 300,000 person years. You can see that the HBs zero clearance is very, very low, 1.02%. So it's almost nothing. And there's no difference between male and female. But there are certain characteristics of patients who might be able to achieve HBs clearance. And these are the patients who are anti-HBe positive at the beginning of treatment. They have low DNA and therefore, again, fits into the criteria of the anti-HBe positive HB hepatitis B patient. And if you quantify the HBsAg protein, they have also low values. Like, for example, here 2.74 IUs per ml is a predictor of a zero clearance in the future when you're giving drugs. So, therefore, today, when patients ask you what are my chances that I might stop treatment, of course, your answer is, yeah, when we clear your HBsAg, then that's the time that we stop treatment. And what are my chances with my characteristics today? What are my chances of getting that HBsAg zero clearance? Then the answer is, if you are anti-HBe negative, your baseline DNA is low, like 6 million or less, or low baseline HBsAg. Now, the genotype and the treatment history doesn't have any impact on zero clearance. And so at the end of this particular conversation, maybe you just have to tell them that, yes, we will have a treatment that might be lifelong, but we are going to look at guideposts on which part of your treatment that we might be able to consider quitting because you have successfully achieved some of the outcomes that we like. So this slide, for example, defines what we mean by zero clearance. We have defined it earlier, but just to make sure that we understand each other clearly, HBsAg zero clearance is the loss of detectable serum HBsAg without or with antibody to the S antigen, therefore developing anti-HBs. In patients who achieve this spontaneously or a natural seroconversion or by treatment. It is quite rare among Asians. So therefore, when we treat patients with hepatitis B, if we achieve anti-HBs positivity, that's the ultimate dream and the goal. But if you already lose HBsAg in the serum, that's already considered a success because that means that basically you have undetectable HBsAg. You just have to wait for the immune system to respond later on to develop anti-HBs. If you achieve HBs zero clearance, it is also predicted that your serum DNA levels will also become less or become undetectable in the future. However, let me remind you that only the DNA of the virus in the blood is the one that's undetectable. There are still HBV DNA or there's still HBV viruses in the hepatocytes or in the liver of these patients. So a negative HBV DNA only means that you have negativity of the DNA of the virus in the serum, but not yet in the liver. All right. The third bullet point tells you that yes, as you grow older, there's a higher chance of developing seroclearance. But let me remind you that if you clear your virus at 60, that means that you've been infected by the virus for 60 years. And that's not a good way of existing because clearly there will already been mutations and certain events that might develop in your liver. So that even if you have cleared the virus at 60, for example, you still have to be very worried about liver cancer because these patients have been infected and have been impacted negatively by the virus. Now, there's also a terminology called HBsAg zero reversion, meaning that patients who have been on treatment had lost HBsAg, but if they become sick, they have been on, say, chemotherapy, their immune systems are bad, they can reactivate the virus. And here you call it HBsAg zero reversion. It is quite uncommon, but if you develop anti-HBs status, you might have a very, very favorable clinical course. Point, however, is that while you lessen the risk for developing HCC in these patients, you still need to monitor these patients because clearly, especially if they have seroclearance at an older age, they still have a risk for developing liver cancer. Now, of course, age, gender, and presence of cirrhosis and co-infection with the D or the C virus are important factors in HCC development, which can impact even if you clear HBV DNA and seroclearance, of course, for S antigen. Now, there are reasons why patients will have problems with long-term HBsAg positivity, even if they're on treatment or even if they have a response, because there are certain, characteristics of the virus that is really crazy, that makes them, multiply and hide forever. These are 1, 2, 3 in this slide on the left. Your integrated hepatitis B virus in your genome is always a source of HBsAg. Your cccDNA in the nucleus of the hepatocyte is always a source of HBsAg, and they're difficult to remove. And there are certain variants that are circulating in your liver, in your blood. So if you have achieved a successful treatment, maybe the cccDNA can be diminished but not totally gone, and therefore in some of these patients, HBsAg might be lost. But clearly, in some patients who have integrated their virus in their genome, this is going to be difficult to remove. We believe that patients who have been infected at birth will have total integration of the hepatitis B genome in our hepatocytes by about 28 or 30 years old. So in these patients whom we see as adults, it might be really difficult to make the HBsAg disappear. And so in that cohort that we showed you earlier, 300,000 person years, only 1.02% gets a seroclearance. Now, another question is antiviral resistance. Antiviral resistance is an issue because our drugs are only impacting the polymerase, and therefore resistance is always a big question in our treatment of patients for years. Is it still an issue? I think today we have only very, very good drugs that are available in the market. The drugs called lamivudine, which is the groundbreaker, later on followed by telbivudin, and of course adefovir, which is a weak antiviral. All of these drugs have been implicated in viral resistance, and therefore, we discourage the use of these drugs on your patients. But mind you, there are still certain family medicine physicians that are still treating their patients with lamivudine, which is kind of disturbing. In fact, in an article by Ning, a colleague from Guangzhou, she claims that we need to really continue this campaign, even among physicians, on the proper use of the correct medication for patients with hepatitis B, because this lack of awareness and the use of low barrier antiviral drugs are key in our very bad success rates in the control of hepatitis B in our region. All right, so I think the message therefore is we need to switch to high barrier resistance drugs, and we have mentioned about tenofovir and entecavir, and maybe this is the way to go today and worse going forward. This is a trial that was done, I think, in the West, which tells us that in patients with who had been treated with tenofovir alafenamide, even at as early as week 96, we get very, very good control of the virus. And now we have cohorts more than 12 years being followed up, and we have not seen very, very significant resistance rates on patients with treated with tenofovir and entecavir. And when there is an unfortunate chance that you might develop a multi-drug resistant virus, for example, first resistant to lamivudine given entecavir, and we know that in these patients, even if you use entecavir, they still will develop resistance if they've been exposed to lamivudine in the past. Then what is the treatment that is available to them? I think the treatment for them today is, of course, tenofovir. And you can choose between disoproxil and, of course, alafenamide. And this is the cohort that we've shown you being treated with tenofovir. So in our APASL guidelines, we showed this chart, and I hope that you will read the article. And this is a good advice on what drug to shift to in case that you are going to develop resistance to the primary drug that you use. And here, for example, I put in a red square, multi-drug resistance patients or multi-drug resistant viruses need to be shifted to either TAF or entecavir for both safety and, of course, efficacy. Now, the biggest question, of course, is can we stop nuke therapy? In the HBe-Ag positive chronic hepatitis B, meaning that your HBe antigen is high at the beginning of the treatment, your ALTs were high, and you had maybe several hundred millions of viruses in your patient, we can stop treatment in those patients when you achieve an anti-HBe seroconversion. Let me be very clear. So you start with an HBe-Ag positive patient, ALT is maybe 150, your DNA is 100 million. You start giving them tenofovir. After 3-4 years of treatment, your patients first develop negativity for the DNA, your ALT is normalized, and later on in 3-4 years, you develop an anti-HBe positivity in the serum. Those patients can be stopped. These are the patients who are what we call HBe-Ag positive chronic hepatitis B. Now, in chronic hepatitis B that is HBe antigen negative, can we stop them? Today, we know that in those patients whom we started with, just look down at the second part of the slide, in those patients who are anti-HBe positive, or what we call HBe antigen negative chronic hepatitis B, we can only stop the treatment if we have lost the SBS-Ag. So there's a tall order because only 1% of those patients can achieve that in even 5 years of treatment. So it seems that therefore in those patients with E-negative chronic hepatitis B, you have to treat them forever. However, in the first part of the slide, as I was emphasizing a while ago, if the HBe-Ag positive hepatitis B patient that you treat develops an anti-SBS, anti-HBe, then you just have to give them 1 more year of treatment. I do it 2 years, consolidation therapy, and then you can quit. And at least about 40% of our patients can achieve that. So the question is, can we stop treatment in the HBe-Ag negative chronic hepatitis B patient? Because we said just earlier that yes, we cannot stop them and we have to treat them forever. I think there's data today to show that yes, for E antigen negative hepatitis B, as long as they are negative for the virus while being treated for at least 3 years, we can actually withdraw treatment. There are a lot of data today to show that we can withdraw treatment. We have included that in our APASL guidelines, of the Asia Pacific guidelines, about maybe 8 years ago already, because there's data from Taiwan. And I think there are some other centers. I think my colleague in Singapore have also done this, Singi, who is the teacher of Star De Lunas. Has tried this type of withdrawal therapy on the HBe-Ag positive, negative chronic hepatitis B patients, and there's some success. The important reminder, however, is that we need to watch these patients closely because even the guidelines that are recommending this today, including the ESEL, the European group, is already recommending that you can actually study withdrawing treatment, and I have done that for some of my patients. So what are the predictors of seroclearance in these patients? I think this is one very important study that I would like to show. If you're going to withdraw treatment on these patients that you have spoken to and discussed very well, the patients who had no virologic relapse, so meaning that when you withdraw these patients from treatment and you monitor their DNAs, they never had a positive virus in their tests, those are the patients that will clearly have responded very well. However, in those patients who had some virus in the blood but did not have an SGPT elevation, did not have jaundice after the withdrawal, these are also the patients that can be good candidates that will lose the HBe antigen and might lose SBS-Ag as well. So In these patients that you have chosen to withdraw treatment, monitor them very well with their DNAs and their ALTs, and of course examine them regularly, because the patients will not have a positive DNA 6 months or 1 year after their withdrawal of treatment, and especially if they don't develop an SGPT elevation, if their virus is a little bit high or back in some levels by a few thousands, then these are the cohort of patients that will have a successful stoppage of their treatment, even if they have not lost SBSAG. So therefore, in anti-SBE positive chronic hepatitis B, there's still hope that you can actually stop treatment in this particular cohort of patients. Okay, as a conclusion, therefore, in this particular slide, incidence of SBSAG seroclearance after stopping NUCs is much higher than continuing them to be treated. In patients who have very, very low SBSAG levels, and then we quantify that, of course, by special tests that are available in the country. If there are 100 IUs per mil or not or less, they also have a higher chance of developing seroclearance. And patients with clinical relapse who remain untreated had a better chance of getting seroclearance. And therefore, I think this is the experiments of Sengi, and I think Star can give us some explanation later on in the outcomes of their strategy, because in these patients, as long as you're brave and you're monitoring their SGPT very well, you can actually safely withdraw treatment. Now, I think this is my last topic that I want to discuss with you. What is the implication of metabolic syndrome in chronic hepatitis B? Because this is another great issue today, bigger than maybe COVID. In Asia today, there's some unwelcome growth because while we are richer, we have developed obesity, and of course, coupled with that is diabetes in the Philippines is not far away from anybody else in Asia. The Asians today, including the Filipinos, have become wealthy, but clearly became unhealthy. And the metabolic syndrome is one of those that are plaguing the Asia Pacific as well as the entire planet. Asia Pacific seems to be one of those leaders there. Now, what is the impact of hepatitis B and the metabolic syndrome? We know that metabolic syndrome is going to, chronic hepatitis B is going to progress if they're not untreated, will progress to fibrosis, cirrhosis, and later on liver cancer. And if you have metabolic syndrome on those individuals, then steatosis, obesity, and diabetes is going to impact that particular individual, and therefore increase the risks for developing decompensated liver disease and, of course, liver cancer. Now, even if you have treated these patients and you have stopped the progression to fibrosis, in case that you have all these other components of the metabolic syndrome here on the left, then clearly the advantage that you have received from treatment will disappear if you have metabolic syndrome as a comorbidity in these chronic hepatitis B infected patients. I don't understand why I cannot. Okay, there you go. So metabolic syndrome is a common risk factor for liver cirrhosis in patients with hepatitis B. So a comorbidity of metabolic syndrome and hepatitis B patients really can bring cirrhosis and even liver cancer much earlier in this cohort of patients from China. You can see here, for example, that in those HBV patients that have metabolic syndrome, about 5% of these patients will have cirrhosis on the very get-go, compared to those without non-metabolic syndrome, which is about only 3%. So clearly, the comorbidity of metabolic syndrome in hepatitis B infected patients is a very bad, concomitant condition. So liver cirrhosis is more common in patients with hepatitis B and metabolic syndrome. Seropositive patients with higher ALT levels indicate that maybe they have other issues, and I think I have alluded to earlier about investigative or metabolic syndrome in your patients who are treated with hepatitis B treatment, and yet their ALTs have not normalized. And we have shown in many studies that metabolic syndrome is an independent predictor for liver cirrhosis in patients with hepatitis B. And of course, this has been proven by many studies, including those that involve FibroScan, monitoring over time. Now, having said that, however, we know that in patients with obesity and diabetes alone, even if they don't have hepatitis B, are already independent risk factors for the development of liver cancer. And so if you put hepatitis B into that condition in the same patient, then clearly your lines are going to go up steeply. So therefore, I think the gist of this particular slide is that in patients with hepatitis B and they have metabolic syndrome, then you need to really institute a very good strategy so that you can reduce further harm on these patients. So meaning therefore that we need to control diabetes, we need to control their obesity, we need to make sure that they're not drinking alcohol or any drugs that are going to impact negatively further on their livers. And so harm reduction is the key in these particular cohort of patients infected with hepatitis B. Now, I think I want to end up with this slide. Obesity is, of course, not a negative, not so negative phenomenon in some patients, but I want to warn you this particular slide I just showed because I am very intrigued by these observations. It seems that patients with fatty liver will have less SBSAG positivity. And just focus on the last bullet point on the bottom of the slide, that there's an inverse association between SBSAG positivity and fatty liver, especially in those very obese and old obese. There's a threefold increase in likelihood of losing SBSAG in the very obese patients. And I think the explanation is here in this red, that patients with a lot of fat in the hepatocytes alters the SAG distribution and may lead to seroclearance. And of course, maybe even steatosis-induced apoptosis also contribute to the SBSAG loss. So while it seems that the fat patient might have some advantage in clearing SBSAG, I don't want to make and leave that kind of message because I think that's a very wrong message. Because in this last slide that I have here, metabolic syndrome really is not a disease that you can joke about, because most of these patients will die because of their metabolic syndrome and not from their hepatitis B. So in short, therefore, do not baby hepatitis B, or do not just dismiss hepatitis B in your patients, because if they have other conditions, which I think about half of your population today are in, like metabolic syndrome, obesity, diabetes, and these patients are at risk of getting a sudden cardiac death rather than their liver disease. So patients with hepatitis B can die from cirrhosis and liver cancer, but patients with metabolic syndrome on top of their cirrhosis can actually die from a heart attack and a stroke rather than from their liver disease. So, I'm a Visayan, and so I have this particular mispronunciation of some phrases here, sorry. Okay, so I think I am here, I'm done, and I am very glad to have shared with you some of my confusions that I have hopefully clarified to myself, and of course, hopefully I have clarified to you. And I'm very sad that time is so short. So thank you very much for your attention, ladies and gentlemen, and thank you to PCP and SSP. Congratulations to your efforts, and of course, let's celebrate World Hepatitis Day with a lot more campaigns against hepatitis B. Thank you very much for your attention.
Thank you, Professor Soliado, for your very comprehensive and informative discussion on the current treatment of hepatitis B infection, as well as the issues that we have regarding treatment and updates regarding the treatment of hepatitis B infection. So to join Professor Soliano on the floor for our Q&A portion, may I now again call on Dr. Karen Estel de Lunas, who is the current public relations officers of the Hepatology Society of the Philippines, and who will be the moderator for the Q&A portion of this segment of the Health Forum. Now, I see that there are already questions.
Hello, good morning.
Yes, good morning, Doc. Doc Star and Professor Soliano, you have the floor for the Q&A. Sige po.
Hi, Doc Kat. Thank you for the introduction. And I would personally like to thank Professor Soliano for accepting our invitation to give this talk. It is indeed a privilege to share the same platform with you, being my mentor. So every year we celebrate the World Hepatitis Day on July 28th, and we appreciate you, Professor Soliano, for continuing to share with us in this vision of increasing awareness about hepatitis. So while we are waiting for, we already have questions in the Q&A box. Shall I shoot the first question, Professor?
Sure, no problem. Thank you.
Okay,
so the answer them.
Yeah. So if we are not able to answer, Dr. Wendell is here with us.
The president will answer, yes.
The first question is, can we start antiviral for hepatitis B without HPV DNA and biopsy due to lack of resources? So I guess this is very relevant, especially to us, including me, who practices in the provinces wherein HPV DNA is not readily available. So can you answer the question?
Yeah, biopsy maybe can be dispensed with, but I think the DNA may have to be determined, because there's no way that you can measure success of your treatment if there is nothing that you can measure from the very beginning and compare it with while you're on treatment. And so to me, ALT and DNA are the only tangible and doable stuff in the Philippines that we can do. And therefore, DNA is a little difficult to perform in areas where maybe there are not many laboratories. But maybe many of the big cities today already have PCR facility, and I think the COVID pandemic has made a lot of molecular labs in the country, and we can use them to measure DNA. I think the DNA needs to be part of the initial workup. The biopsy is not necessary.
Okay. So if I may, Doctor, is it okay to contribute to the discussion? So
you're a hepatologist too, so you can answer all the questions, in fact. Yeah.
No, I mean, in the HSP, we have been going around the country giving lectures to primary care physicians, and because we want to empower them in the treatment of hepatitis B, and we have faced a lot of questions regarding this issue. So, well, if DNA is not available and the e antigen is available, if the ALT is persistently elevated, and when the other possible risk factors for elevations of ALT are already ruled out, like fatty liver disease, alcoholic intake, then we may consider starting therapy for hepatitis B patients, and you may consider referring them to specialists. So that is usually how we address this issue. No, because let's face it, we can't sometimes we can't do anything about this lack of resources. So another question. Patients or first-line meds.
The SSP is a model of looking at the pre as well as to determine which patients might need treatment. APRI, of course, is a score where you can reflect more fibrosis and maybe even cirrhosis. And if these patients have hepatitis B positivity in their serum, it's also a good strategy, and I will probably recommend that as well in those with more severe fibrosis, using APRI, for example, that you can start treatment even if you don't have DNA. But then if you have a very young patient, like say 30 years old, and your ALTs are the only ones that are elevated, you have to speak to the patient for a long time because really treatment is going to be long, and therefore they will need measurements in the future. They will ask you, Doc, ano ang success, ano ang proof ng success ng treatment natin? Ano, di ba? Of course, if the ALTs come down and you don't have any other reasons why the ALTs are elevated because they don't have metabolic syndrome or any other drug intake, for example, then that's also a good measure of success, even if you have DNA. Yeah, I can.
That's right. Totally agree with you. So, if I may just share as well, so the HSP has this project called the Liver Tool TH app. You can access it in the internet, and then all of those calculators, including the apnea scoring, you can access it through that app.
Yeah.
Okay, so shall we proceed because we are obviously lacking time here, no? So good morning, Professor Soliana. I have a question regarding prophylactic treatment against reactivation in hepatitis B. Aside from chemotherapy and stem cell transplant, do we also need to give prophylaxis for those who will undergo surgery, especially if it involves the liver, like hepatic resection, TACE?
Great question. I think there's data. Basically, first was produced from Korea, for example, which show that even in those patients who are undergoing TACE for, like, especially what you mentioned, the question mentioned, TACE, chemotherapy, liver surgery, these patients are prone to develop reactivation, even if they're only SPSAG positive. And so, yes, it is recommended. The guidelines recommend that a prophylactic nuke therapy before the surgery or before the TACE, before the chemotherapy, before, or even if you develop a severe condition, even just severe infection, you have to consider also trying to see whether you have reactivated. But as a prophylaxis, yes, in those situations, it is recommended.
Okay, including hepatic resection.
Yeah, clearly, hepatic surgery, yes, and
Okay.
TACE.
This question is from Dr. Yolanda Carrera. What are the chances of getting hepatitis B after completing the infant immunizations?
Sandali lang, Yolanda Carrera, is he a classmate of mine? She's from Guam. She's listening to this talk. Wow. Okay, hi Yoli. What's the question again? I forgot, sorry.
So the question is, what are the chances of getting or acquiring hepatitis B after the completion of infant immunizations?
Well, very, very small, very small. The risk of getting infection after a successful vaccination is really very small. And therefore, it is the campaign today. Most experts even believe that if you have received 2 shots of the vaccine, you are quite substantially protected. So therefore, the issue is get vaccinated. You have to complete it, of course, three injections. But even if you only finished 2 injections, that's kind of protective to the toddlers or the infants already. Yes.
Yeah. So to add to that, no, so the vaccines are their effect are very durable, and there is also a role in checking the levels of the anti-HPS, especially those who have high risk of exposure. So if your levels are less than 10, then you should get a booster to achieve adequate protection. No? So maybe I think I should recognize this from Dr. Diana Payawal. So great talk. Salamat po for giving PCP the time. Why do you think, the question is, why do you think is reason why our prevalence rate is not dramatically decreasing as compared to other countries?
Diana, we have this point about this. It's really so bad, our performance here in the Philippines. We notice, for example, that we compare the Philippines to the so-called communist countries in Southeast Asia, like Cambodia, Vietnam, Laos, or those countries that have just came out of the war are even succeeding better than us. The fact is, even Indonesia is succeeding better than us. Well, my take really is that the Philippines is so poor in establishing or working on policies. We have always argued why we need a law to be able to successfully implement a program. So one is we are not doing well in exercising or executing the plans of hepatitis B vaccination. Second is that while vaccination is free in the public sector, it is not free in the private sector because most private hospitals are charging for vaccinations even when they are supposed to be free. So these are barriers that need to be addressed properly so that our vaccination is going to succeed. So our deliveries need to be in the hospitals because most of our or half of our deliveries are still in the house, and therefore, first those birth vaccinations are not given. And lastly is the follow-up or recall of the patients that have been vaccinated the first time. I think Fabelia is very successful in the program in recalling patients to complete the 3 vaccines, but some other hospitals in the country, even in the big cities, are not doing this. And so these models fail miserably because of execution failures, I think.
Thank you for that. Thank you, Dr. Rapayawal. So, although it's my job to recognize all questions, but it's also my job to make sure that we are on time. We would like to thank all those who have sent their questions. And we also, again, I'm thanking Dr. Soliano, Professor Soliano, for giving this very informative talk. Thank you very much.
Thank you. Thank you. My pleasure.
Thank you, Professor Soliano and Doc Star de Lunas, for that very informative discussion and yung inputs you on the treatment of Hep B. So we all indeed learned a lot. I'm pretty sure ang daming ang questions pa, but we are sorry we ran out of time. Baka we can answer it in the chat box if you can, Doc.
Text mo na sa akin.
Yes, Doc, we can send it to you. So, of course, before we end this health forum, I would like to welcome, and it is my honor to welcome our closing remarks speaker or for today. He is Dr. Wendell Espinosa. He is currently the president of the Hepatology Society of the Philippines. Okay, as well as he is an active staff at the section of gastroenterology in Dr. Pablo Torre Memorial Hospital in Bacolod City and a active faculty in the College of Medicine in the University of St. La Salle, Bacolod. I would now, it is my honor to welcome Dr. Wendell Espinosa to give us our closing message for this very timely topic and condition. Doc Wendell.
Hi,
Hello
good
po.
morning. On behalf of the Hepatology Society of the Philippines, I would like to thank everyone for joining us today in celebrating the World Hepatitis Day. I would like also to thank the Philippine College of Physicians for always supporting our advocacies. And of course, we would like to express our gratitude to Professor Soliano for sharing his insights on this timely and relevant topic. Hepatitis B is one of the most devastating disease, but it is also one of the most preventable and treatable. The most recent national study estimated S antigen seroprevalence to be 16.7%. Without medical monitoring and treatment for chronic hepatitis B, the risk of progression to liver failure and death is up to 30%. Unfortunately, too many people still miss out on services to prevent or treat hepatitis. The reason for people miss out on services for hepatitis are the same as the reason they miss out on other health services, especially in low and middle income countries such as ours. These are accessibility, affordability, stigma, discrimination, amongst others. To achieve hepatitis elimination by 2030, we need to urgently simplify hepatitis care and make it more accessible to more people in need. Thank you once again for your continued support to the Hepatology Society of the Philippines.
Thank you, Doc Wendell Espinosa, for your closing remarks. Again, in behalf of PCP and the viewers of PCP, I would like to thank all that who have joined us, and I would really like to thank the time, effort, expertise regarding this very timely health condition and how we can address it and the treatment of hepatitis B infection. I would like to thank the Hepatology Society of the Philippines, Professor Soliano, Dr. J.M. Ko, Dr. Star de Lunas, and of course, Dr. Wendell Espinosa for joining us again in this health forum. And before we go, I would like to give some further announcements for the upcoming PCP activities this coming month and the upcoming months. Can we show the upcoming activities po in the Sir Jerry and Sir Lloyd? Can we show them? So for this coming Saturday, July 22, we will be having our Radio Veritas program, and the title for the program is Mga Impormasyon sa Diabetes, ating tatalakayin at alamin. This is with our speaker guest, Dr. Eduardo Thomas Aquino, and our anchors for that would be Dr. Toralba and Father Joel Sabalia. So this will be in participation or in lieu of the celebration of yung National Diabetes Awareness Week. So this will be held on July 22, Saturday, 9 to 10 a.m., which can be seen through Facebook Live and the Radio Veritas Facebook page. Okay, and then we also have an upcoming webinar series from the Philippine College of Physicians again. This is entitled Convergence, the evolving paradigm in hepatology and oncology through the lens of an internist. This will be held on Saturday, July 29. So next Saturday, July 29, 6 to 8 p.m. via Zoom. So our speakers and panelists for this talk will be Dr. Diana Lachica, Dr. Ian Homarkua, Dr. Annalyn Beryl-Ong Cornell, and Dr. and Professor Diana Payawal. So this will be via Zoom, and you can scan to register the QR code at the picture there so that you can join in the Zoom webinar. Okay, and then for in collaboration of the Philippine Society of Medical Oncology and the PCP Committee on Advocacy Committee of the PCP, we have the Cancer Fair 2023. This will be held on August 6, 2023, 8 a.m. This is the nationwide. 8 a.m. August 6, 2023. It will be held on Luzon, Visayas, and Mindanao. And then yung mismong cancer fair in the Cupans City, the cancer fair in the Cupan City that will be held in CSI Stadia, Emerald Hall. Sunday, again, August 6. This will be held from 8 to 1 p.m. at Daguban City, Pangasinan. Okay, so without further before we go pala, Professor Soliano, may we ask for a public reminder what to do to avoid getting hepatitis B, also the signs and symptoms, and what to do if you suspect you have hepatitis B, for a take-home message for the viewers, for the general viewers rin po.
Okay. Most hepatitis B infections are acquired at birth. And so screening the mother for hepatitis B is really important for the OB colleagues and for the mothers to be. And then, claro, vaccination at birth and then finishing the vaccination. As an adult, we tell you that maybe getting, blood transfusions from very safe labs or hospitals is important. Make sure that the tattoo and all this other stuff that you inject now on your bodies are safe and clean. And lastly, of course, is in the age of experimentation, as we said, make sure that you are, good behavior and not risky behavior is important.
Okay, thank you, Professor Soriano, for your take-home message. And lastly, but certainly not least, I would also like to welcome the new members of the Committee on Media Communications. We have two new members, that will join us to be moderators in this health forums. We have Dr. Faye Carissa Bautista and Dr. Paulo Vergara. So again, we have extended, but I'm sure a lot of people have learned a lot about hepatitis B. So, and the current treatment guidelines and updates. So, everyone, thank you everyone for joining us today, and hopefully we can see you in the upcoming PCP Health Forums as well as the other activities that I have announced. Thank you everyone. Keep safe. Sige po.
Thank you.
The Philippine College of Physicians,
Yeah.
through the Committee on Media Communication and Health Forum, wishes to thank its media partners, social media followers, and participants. See you again next time, here on the PCP Health Forum.